The field of MRD has evolved gradually over a very long period of time. Early work focused on just a few number of colors with flow cytometry machines, focusing on some of the leukemias and other diseases. In multiple myeloma, my interest started in early 2000s, and in 2009, we launched the evidence meta-analysis. That study came out of the NIH, and it was developed over several years, and eventually the I2 team developed their project, and there were 2 studies going forward. There are a lot of other initiatives by institutions that have been going in parallel as well. For all these years, different studies tried to see if MRD could be achieved at higher and higher rates, and gradually the efforts I mentioned with the evidence meta-analysis and subsequently the I2 study looked to see if MRD was a predictor of clinical outcome. In April of 2024, the data was presented to ODAC by the FDA, and they voted 12-0 unanimously in favor of MRD becoming an early endpoint for accelerated approval. So the myeloma field really come all the way from developing from primitive to more advanced technologies, from looking at the individual studies to pooling it into the evidence analysis and subsequently the I2 study, and showing that this could be an endpoint for drug approval. What we are seeing now is that MRD is also gradually being used as a tool for treatment decisions, and more studies, even randomized phase 3 trials that have been published in premier journals, have used MRD as a tool for decision making. We see that more and more studies are looking into this. We see how MRD starts to play a role in smaller myeloma, in some of the immunotherapies, in the CAR T-cell therapies. My prediction is that eventually MRD will not only be an early endpoint for accelerated approval. I think it will be the final endpoint, the primary endpoint for the full approval. But we need more data, we need larger data sets, we need more robust analysis to prove that that is the way to go. But that's where I think we're going to eventually land.